Next talk is by Dr. Praveen Kulkarni. Uh, the newer immunomodulators in the cardiology actually, newer immune checkpoints in the inhibitors in the heart role. To Dr. Praveen Kulkarni.
Good morning, everyone. Thank you, AOC. Thank you, Dr. Pelajani, sir, Dr. Sharma, Dr. Gupta, Dr. Milin, and for giving me this platform. It's a tough shoes to fill in now after this lucid presentation by both Dr. Kane and Dr. Rajani. My slides won't flow as smoothly as Dr. Rajani's for sure, and there's something for all of us to learn. I think beautiful slides. Moving on to the topic that was given to me, it's immune checkpoint inhibitors and heart. So this is a specialty I think is not yet addressed as the need is. With the survival of cancer improving, the need for a dedicated oncocardiology care and as a subspecialty, understanding the nuances of that is ever increasing. So this is a beautiful slide, and a lot of my slides are from the latest guidelines that has come up in the ESC for cardio-oncology in 22. So this slide is talking about the cardiovascular therapy-related cardiovascular toxicity. So it is written as CTR-related CVT. As the risk increases, so does our need to intervene. So there is indication to intervene at 3 stages in all onco patients undergoing therapy. One is in primary and secondary prevention, one during the cancer treatment, and of course in cancer survival programs, survivorship programs. So there's a sustained need for acting in all 3 levels of cancer treatment so that we reduce what is now commonly called as CTR-related cardiovascular toxicity. So the flow of my talk today will be brief as to what are immune check inhibitors, why is it relevant to us cardiologists, what are the major adverse side effects when it comes to ICI, cardiac as well as non-cardiac, how do we identify and manage these patients. So what are immune check therapies? Now, looking at this slide, the first time I saw it, we all have gone through the slides in Harrison. Having only been reading neurohormonal, RAS, SNS, not much of cellular level science, this seemed a little daunting. But let me spend a minute or two on explaining what immune checkpoint inhibitors really are. So whenever there is an onco or any infection, we need T cell or cytotoxic action against an invading organism, a malignancy, and it is driven by T cell. T cells are, the activity of T cells is triggered by various co-stimulatory antigens. Also, there are checkpoints within this stimulatory mechanism. So what are those checkpoints? If the T cell activity continues unhindered, it can be self-destructive. So these are called checkpoints. These checkpoints are in the form of PD or PDL or in the form of CTLA. Let's not get into the names of these. What they essentially do is the inhibitors of these checkpoints, which are monoclonal antibodies, if I can give an example here, there is a PDL1 and PD1 co-stimulation, which causes inhibition of T cell activity against tumor cell. So monoclonal antibodies acting against this PDL1 or PD1 can prevent this immune activation inhibition, which restores the host T cell immunity towards cancer cell. So you're basically acting against those immune checkpoints, allowing the body to harness its own cytotoxic activity against the cancer cells. It came up first in 2011 for a malignant melanoma, metastatic malignant melanoma. And there have been rapid strides, and it has been used extensively now for advanced malignancies, metastatic malignancies, for various solid organ tumors. And you name an organ, it has been tried and utilized in those malignancies. Now, why the toxicity? We all understand that now these are monoclonal antibodies that block the immune brakes. A sustained T cell cytotoxic activity is what we achieve by this. It helps in clearing the malignant cells. But as a counter thing, it can overactivate or trigger cytotoxic action against non-cancerous cells. And that is where you have immune-mediated adverse events. These are widespread. The rate of immune-mediated adverse events is to the tune of 7 to 20%. The most commonly affected organs are skin, where it can be rash or vitiligo, pruritus. The other dreaded complication of ICI immune adverse effects are related to endocrinopathies, thyroid, hypophysitis, adrenal insufficiency. It can also affect gastrointestinal. It can cause pneumonitis. We will largely be, however, restricting our talk to cardiovascular side effects. All onco-related side effects have been categorized into grade 1 to 5, 5 of course being fatal and grade 1 being mild. The understanding the grade of this adverse effects is necessary because our treatment is driven by the grade of the adverse effects. 2019 was the first time we had a nice review that came up in JACC regarding cardiovascular toxicity in relation to ICI. So it can affect at multiple levels in the cardiovascular system. In the myocardium, where it can cause myocarditis, heart failure, cardiogenic shock, or TTS. It can affect the electrical system, causing blocks, AF, and tachycardia, ventricular tachycardia. Pericarditis and pericardial effusion is a known side effect, as well as it can cause vasculitis. So there are reported cases of large cell temporal arteritis in relation to ICI usage. Again, cardiovascular toxicity is divided from grade 1 to 4, grade 4 being severe cardiovascular toxicity warranting hospitalization and need for support, mechanical support, circulatory support. So what are the, again highlighting what are the side effects that can potentially be seen. Myocarditis is what will be our interest in the subsequent slides, described in up to 1% of patients who are exposed to ICIs. Then there is pericarditis, arrhythmia, non-myocarditis related heart failure, MI, stroke, and also a high incidence of venous thromboembolism. Now, ICI myocarditis, it is usually seen in the first few weeks after exposure to the drug. The median time has been reported between 7 to 34 days after the exposure. So what happens is, why is it seen, is there is a cross exposure of this PDL1 in cardiac myocytes. So this immune checkpoint inhibitors which are acting on the malignant cells may end up destroying cardiac myocytes. Now, severe myocarditis is the most feared toxicity when it comes to ICI-related cardiovascular toxicity, and it has reported mortality is around close to 50%. Who are at high risk? I think this is what we need to understand. If they're exposed to dual ICI therapies, so there are different, as we saw in the slides, there are different immune checkpoint inhibitors. If you're giving more than one ICI at the same time, they are at a higher risk. Or other cardiotoxic chemotherapy, and anthracycline, trastuzumab, if you are exposing them to other drugs, other chemotherapeutic drugs along with ICI, and of course, if you have pre-existing cardiovascular risk factors, like diabetes, a past cardiac history, so these are ones who are at higher risk. How do we diagnose? So there is a clinical diagnosis for this for the myocarditis, and of course there is endomyocardial biopsy. This is gold standard. The problem with endomyocardial biopsy is most often the decision ends up being clinical. Biopsy reports take time. In suspected myocarditis, the treatment has to be prompt and timely, and in the first 24 hours itself. So we end up using clinical diagnosis most often. In the surveillance, usually cardiac troponins are always done in patients who are on ICI. Cardiac troponin rise with one major or two minor criteria. That is how we suspect ICI myocarditis. Major criteria is a cardiac MRI suggestive of typical myocarditis. In minor criteria, it could be one of the above clinical symptoms of heart failure, fatigability, orthopnea, PND, pedal edema, arrhythmia, which could be either tachy or heart blocks, other immune-related coexisting adverse effects. And what studies have shown, if someone has a myositis, a muscle injury, or a myasthenia gravis, along with suspected cardiac myocarditis, then the chances are much higher. Also, a suggestive cardiac MRI and not typical as in the major criteria. Of course, biopsy is gold standard. Cardiac MRI, as was elucidated yesterday in evening's talk as well, is now increasingly the modality to evaluate muscle health. So there is increasing talk of about T1 and T2 mapping, which helps us pick up myocardial edema early in these patients. Of course, late gadolinium enhancement is another characteristic feature. Unlike myocardial infarction related, where the LG is typically subendocardial or transmural, here what we end up seeing is you will have an subepicardial or unusual locations of LGE. So this is what differentiates an infarct or an ischemia with a myocarditis LGE. A lot of data has been published. When I did a PubMed search, I found 472 articles on ICI-related cardiotoxicities. This is one of the largest studies that came up in 21. This was where they followed up a lot of close to 25,000 patients, of which 743 of them were related with ICI therapy. Cardiovascular events were seen in 9.7%, and the risk of myocarditis, pericarditis was almost 1.8% in this study. There is ESC recommends that we do surveillance in all these patients. Depending on the low and high risk, we do a baseline cardiac assessment, ECG, echo, troponin, and natriuretic peptides in all these patients. And based on the risk factor, we would also, between every cycle, do ECG and troponin. So this is one more take-home message I want. Anyone who is on ICI therapy should have their ECG and troponin levels done before every cycle. The treatment, again, is largely driven by the severity of the grade or the grade of the myocarditis. If a suspected fulminant or non-fulminant grade 4 myocarditis is suspected, admit in the ICU and you pulse them. Waiting, even pending investigations, recommendations say you pulse them with 500 to 1 gram of methylpred. If they don't respond, then you go to second class of drugs, which could be ATG, infliximab, or MMF. Typically wait for 24 to 72 hours to see for clinical response. Also, if there is a need for MCS, it should be initiated early. The management there are on standard lines of any fulminant myocarditis. So quickly, other immune-related adverse effects are, it could be Takotsubo, it could be LV dysfunction without myocarditis. Of course, we always make an effort to exclude myocarditis in all these patients. Various arrhythmias have been described, either related to myocarditis or thyrotoxicosis or de novo as well. Pericarditis is a distinct entity which could be with myocarditis or independent of it. If it is pericarditis without myocarditis, prednisolone and colchicine is recommended. Interruption of ICI therapy is needed in patients who develop moderate to severe pericardial effusion. Of course, post-therapy care is essential. A multidisciplinary decision is recommended before restarting ICI therapy. Now, ICI is sometimes the only option available for advanced malignancies. So careful MDT is needed to take a decision whether you reintroduce these drugs or not. Continued surveillance is at 3, 6, and 12 months is recommended in all these patients. And for patients who develop severe immune reactions, a lifelong surveillance. So final take-home message is cardiac oncology is beyond giving fitness and saying fit for surgery with low risk, high risk. We need to understand the nuances, the newer drugs that are coming up. The resultant toxicity is relevant to the heart, we need to understand. ICI-related cardiac toxicity is real. Through this, I think we understand the need for surveillance and also keep a low threshold for identifying myocarditis. Early detection and immunosuppression is necessary, and surveillance in post-care is also of equal importance. Thank you.